Well, welcome to this talk, and I'm delighted to welcome back Professor Angus Dalgleish after the last fascinating talk, Professor, that got such amazing feedback. Thank you so much for coming back.
You're welcome.
Now, the first thing I want to ask about, I've just been overwhelmed by people asking about your mycobacterial vaccine. Now, if I can just tell you what I understand this. So myco generally means fungus, but these mycobacteria, the colonies look a bit like a fungus. So I think that name's kind of stuck. And you take these simple bacterial organisms, you kill them, and then you transfer them into an injection. And this seems to have really quite incredible generic properties against a wide range of, well, certainly against melanoma and potentially against other cancers and potentially against other bacterial and viral infections.
Mm-hmm. Well, first of all, I didn't do that, and I don't do it. But I got into this because I was really looking at the immune response of melanoma patients because I realised it was abnormal. Didn't really know how to measure it. And then when we could measure it, we found that all these patients were suppressed in their T-cell responses, what they call cell-mediated immunity. And one of the people I was working with and bumped into at meetings was trying to develop a much more effective BCG vaccine, which is the TB vaccine. But BCG, which stands for the three people who discovered it, it is attenuated, for it's live, but they passage it so it's no longer dangerous. It has advantages, but there are clear limitations with it. So this group, which was John Stanford, Graham Rook and John Grange, basically looked for BCG-like organisms, mycobacteria organisms. It was very clever because they realised that some places in Africa the TB rates were very low, and they wondered if there were bugs out there that could explain this. And they found one such bug. They found many, but they found one that seemed to fit the bill, and it was called vaccae. So it's Mycobacterium vaccae. Vaccae is Latin for cow. So it was associated with cows. It wasn't found in places without cows. Anyhow, I think actually their sort of piece of brilliance with this was, instead of trying to live attenuate it like Bacille Camille Guerin, they tried to heat kill it and went through different ways. And the proprietary is the fact that they found that certain ways of killing it and borate buffering led to a very antigenic and immunogenic agent. And that's really what they did. And they have done TB trials and shown it to be very effective. And more recently, there were other people who showed it was effective orally. So instead of injecting it, they've done that orally. I, however, when I saw what it did in the immunology, and I had a shared PhD student with these people, I said, let's give it to the cancer patients. Now, in these days, you didn't have to go through lots of regulatory authorities, what have you. I basically, they said they would supply it, and I asked our ethics committee, who basically said, well, if you're not going to kill people, go ahead. And I said it's been in hundreds of TB, a TB vaccine with no problems, so we went ahead. And we found that it rescued the suppressed immune response in our melanoma patients. We sometimes had to, depending on how suppressed they were, we had to give them perhaps 3 or 4 injections before it boosted it up. And this was where I got the insight into the COVID, is it was the fact it was heat killed. You could do this with a good effect and no negative effect. Had I done the same thing with BCG, and I'd used BCG for other cancer vaccines, you lose the effect after the second injection. But here, I think it's because this was heat killed, and it boosted the T-cell response, and it never boosted the antibody response. And that's when I realised that is what you want, because often I would see patients who had melanoma all up their arm or their leg, that when they hit a certain level, the disease all started to disappear, and I could correlate it with a resurgence of a T cell immunity which had been suppressed. So that is what me got into being very interested in this field. These patients went on to tell me eventually that they never got colds or flu ever again once they were on this program. And that's when I began to realise that this was really a bit of a universal T-cell vaccine. And I, for one, was impressed that a lot of these people gave up having flu vaccines, so no negative effect. And this went on. I mean, I've been using the VACI for over a decade, and then it was switched to Obiensi when the company working with VACI decided to change horses, as it were. They totally changed the technology. They thought it was a bit too old and steam-driven. Well, that is the beauty. Sometimes the old steam-driven work really well. The high-tech just encounter new problems all the time. So I persuaded another company called Imodulan to take it on. And John Grange, unfortunately, who's passed away, he basically said, if we're doing this, let's go for Obiensi. It's better than VACI. So if we're going to recommit to new production, etc., go with this because it's much easier for quality control. Well, being a realist, I said, well, that's great, but I want to make sure it's as good as, because it might be a foible of the other one that makes it really good. And by making it cleaner, it's not going to work as well. So we did studies which showed that it not only worked as well, but was even better. It induced even better response rate. So we went with that for our definitive trials, and the best definitive trial was in pancreatic cancer, which showed a highly significant survival in metastatic pancreatic cancer when given with chemo versus chemo alone. And that is what the company is going to try and get it registered for. I personally feel that the data is so strong, the side effects so few or completely absent apart from a reaction at the site of injection, it should be given approval now. I cannot see the need for a bigger study.
Indeed, and it's not ludicrous to think that if I was to take this now, not only would I get less colds and flus, it would increase my T-cell response, and that would potentially protect me from a whole range of cancers.
Well, it might not necessarily protect you, but it would certainly reduce your chances of developing them early.
Well, that would be good enough for me, Professor. Absolutely, yeah.
As I mentioned, the problem with the COVID vaccines, the boosters, is they were perturbating a T-cell response, which is already controlling cancers you didn't know you had. And that's one of the reasons we're seeing so many B-cell lymphomas and leukemias, because they're well known to be contained and only come out when the person's suffering from something else.
Right, so things like B-cell lymphomas and melanoma.
And melanoma in particular, that seems to be very well contained by immune response. But eventually it wins the battle and suppresses. And I think all cancers do that.
So I could potentially have a B-cell lymphoma, but it's just kept in check.
Yes. And
by my active immune system.
Yeah. The older we get, the more likely that's the case. It's when that system fails, you rise up. And I mentioned before, the innate T-cell response falls from 45 down to very low when you're 70, and the cancer incidence starts really rising at about 55 and is quite high by the time you're 70. That's they correlate very well. Doesn't mean to say they're causal, and that's why we do research. And the more research I do, the more I think they're related.
So, just to ask a geeky question, does the melanoma actively suppress the T-cell system?
I believe it does. We haven't had the opportunity to do that in the way that I've had with colorectal cancer. The best data I've ever done, and I've published this, and I think it's one of my really best papers, because we had the way of showing immune suppression in cancer patients with the T-cell response, a very elegant assay. And I had a very bright colorectal surgical colleague who had good registrars looking for projects to do. And I got them, I said, let's look at the T-cell responses of these colorectal people before you do the surgery on them, and then we'll look after. It was unbelievably black and white. Every single colorectal cancer patient had a suppressed T-cell response.
Which is chicken and egg there, though? I mean, is it the suppressed T-cell response leads to the colorectal cancer, or is the colorectal cancer down-regulating the T system?
We obviously thought about this a lot because there are patients in which it's the cancer has arisen early on the background of chronic inflammation, such as ulcerative colitis. And we've shown that chronic inflammation causes T-cell suppression. So it's the cancer suppressing the T-cell response unless it arises in a strong chronic inflammatory state where the T-cell suppression's already been done. But here is exactly what confirms it is the tumour that takes over, has reprogrammed the immune system, because 1 month after we had the patients had their tumours completely removed, they all had bounced back into the normal immune response range. So it couldn't be clearer. Yeah. And then we went on and did something which then showed it is the immune response, the innate immune response and the setting that determines. In these people who bounce back, let me put it in a box way, these patients all had an immune response like that compared to like that for normal people. And when they bounce back like this, but there was a few slightly lower, the lower end of normal. We followed these patients up over 7 years. The people who bounced back at the lower level were the first to die. Indeed, the 7 lowest people had been reset low, they were the first 7 to die, irrespective of what other treatments they were given in chemotherapy. So that told me this is supremely important in your cancer control.
Isn't cancer a clever disease? It can kind of take over and say, oh, well, these T cells will be in the way. Let's suppress the T cell activity. It's weird.
Well, that is why the T cell response is so important, that it ain't going to be a problem unless it overcomes that, and it finds a way of evading the response, which is why if it's got a big antigen, on the cell surface, and you target that, within 3 months the tumours come back and there's no antigen on the cell surface. It's got other ones. So it is a constant battle, spy v spy, as it were. So
it's an evolutionary battle, isn't it?
It's an evolutionary battle, exactly.
Yeah. Right, just practically, if I go to my doctor now, will he give me this mycobacteria obensi vaccine?
Well, no, because the problem is it hasn't been approved yet.
No.
Doctors aren't allowed to use things until they have been approved, which is why I'm so desperate to get it approved. The data pack for pancreatic cancer is enormous. The minute it was approved for pancreatic cancer, I think you then do what they do off-label. It is like the new immunotherapy things like Pembro. They got licensed for melanoma, and now they're licensed for about 23 different tumour types. I mean, that's the way it goes. But I actually think because of the data of it resurrecting suppressed T-cell immunity, it should also have a license for protection of innate T-cell suppression.
Mm-hmm. I mean, it sounds like, I've, in clinical care, it's all about risk-benefit analysis to me. If someone's got pretty well any cancer or serious infection, what would be the downside in giving them mycobacterial obensi vaccine?
Well, there is none. I mean, you can get a similar effect with BCG, which, as I said, is the first one, which is live attenuated, because if you give a booster of BCG after the first 2, there is a downside. You start getting a background inflammatory response, and if you give another booster, it's so inflammatory it'll actually promote cancer growth. So, and yet this is an agent with accepted anti-cancer activity because it's used for bladder cancer, where they squirt it inside to the bladder.
The BCG is?
BCG, and it's actually approved for that. But you wouldn't want to give that the way we would give the heat-killed mycobacterium, because it would cause too much mayhem.
So, I mean, I don't see any reason why these mycobacteria preventive vaccine shouldn't be something to try.
Well, I mean,
as a first line for anyone.
Yeah. Well, I think that the data for pancreatic cancer is so strong it should be approved as it stands. Yeah. I really do. I mean, this idea this is what they say, we need bigger trials just to make sure it's safe. You don't need bigger trials to make sure it's safe. You do bigger trials because something doesn't work very well and you've got to do lots of people before you show a small benefit. This is something that's been in thousands of people for TB in its development.
I'm starting to feel a bit angry now, because if I was bright yellow, itching all over with terminal pancreatic cancer, I wouldn't care less about these regulatory bureaucracies. Exactly. I would want the treatment from you.
Exactly. And the real irony, as you know, these are regulators who are so over the top about non-existent side effects who haven't given a damn about the glaring side effects of vaccines they've approved for everybody.
The irony, just...
Exactly.
How do you express the emotion of that irony? It's it's just intolerable, absolutely intolerable. So if there is a trial, we will publicise that, because I've got about 1,000 volunteers already. I'm at the top of the list, and we'll certainly go for that.
I'm certainly going to give the feedback to the company that's doing this, because I think that's very important information that they need to know. This has much broader application. It also, and I make no bones about pushing this here, that the IMM 101 is
this is the mycobacteria preventive vaccine.
Yes, that's its trade name. That's what it's called. Its proper name, and it is heat kill mycobacteria obiense. But it is the proprietary is how you kill it, how you stabilise it, how you make it antigenic. That's the so-called secret of it. But I personally believe you don't need the government to give billions away for messenger RNA factories to create the variants of the future. No, because this pandemic has shown by the time you make a vaccine against one variant, by the time you get it out there and start putting it in the population, another variant's popped up. And we know the bivalent antibodies to cope with this, and which Moderna and Pfizer are all telling us work brilliantly. No, they don't. Because of all the things I discussed in the last video, they are of no use at all. Whereas once you boosted your gradually sleeping and retiring army of T cells and woken them all up and recharged them, they don't need any further instructions. They will see their viruses. And what's more important, they will see similarities that T cells will see. And if they're good T cells and they sense a new variant coming in, they program the relevant B cell response. You don't need a vaccine to try to predict the B cell response. That just confuses things, which explains the papers we showed that patients who had a good immune response to COVID and never had a vaccine have a far, far better immune response than those who've had any number of vaccines.
Yes. So the physiological way is that the T cells control the B cells.
Yes.
The T cells help the B cells. The B cells say, fair enough, T cells, I'm going to start pumping out antibodies, and they do.
Yeah.
To try and shortcut that physiological process, to shortcut a human physiological process could be described as arrogant.
Yes, and unnecessary, I believe, in this situation. We were all bullied and frightened and feared, as they say in some places, into thinking this was really serious, and we had to do everything we were told, otherwise we'd all die. And that person who should come forward and be held to account is Neil Ferguson and all the people that went along with it. It's absolutely despicable and disgusting what he did, and a misuse of influence, I think, because they admitted they only ever gave the worst case scenario.
Or the people that listened to him. I mean, you could argue that Neil's just an academic sitting there churning out numbers. If people are stupid enough to take those numbers at face value from mathematical modelling with many possible confounding variables, that's their own stupid fault.
Exactly, especially as all his previous stuff's been completely wrong, to which I refer to. mouth disease couldn't have got it more wrong.
Couldn't make it up. Yeah. Right.
So,
Right, so we look forward to those clinical trials with eager anticipation, and I just hope they come before I get a severe viral bacterial infection or, God forbid, a cancer. I would be well up for that.